delegates to the seventh Atofit CV Journal Club, and we are very excited to have all the expert panel here present in the panel box. Let me welcome Dr. Anil Dhal sir for moderating the session, and we have already covered the first topic of the year 24-25 is a journal parade, a trial parade, some may call it, and we have covered four trials into this, and we are going to cover the furthermost. So all are there. So not to wait further, I would like to proceed the today's meeting and handing over session to the Baishali, a medical advisor. So over to Baishali.
Thank you, Anand sir.
Yeah,
So
I
it's
just
yeah. So
speak
very
it.
good evening, one and all. So it's an absolute pleasure to welcome on board all of you today for another very interesting Atorfit CV Journal Club webinar and trial parade part 2. This season is again the continuation of the deep dive into the landmark cardiovascular trials, which are changing the therapy. And I would also like to welcome today our esteemed panelists and delegates, Dr. Anil Dhal sir, Dr. Sarita ma'am, Rao ma'am, and Dr. Praneeth sir, to give us valuable insight and very interesting trials are going to get discussed. And a lot of questions also we are expecting, because all the trials which are going to get present today are new, and something or other will definitely come up from those trials. So without taking much of time now, I would like to get into the discussion mode and see more of the trial part and interesting findings from them. So over to Dhal sir.
So, thank you, Baishali. Thank you, Anand. And thank you for this opportunity. And I have very illustrious colleagues. Dr. Sarita and Praneeth are here. And we are today going to take off from where we left off in a way. So we can start off by just saying that this was a 2024 trial parade, but we can jump straight to where we are, which is, I think, somewhere here. We had discussed a few trials. We had discussed danger shock. We had discussed prevent. We had discussed trial illuminate, and we had also discussed reshape heart failure 2. So I will actually start from a slight discussion on the partner 3 trial. And what is actually timely is that I know that a lot of people who follow the cardiac literature or the cardiology on Twitter would realize that the last few weeks have been dominated by a brilliant editorial, a very thought-provoking, insightful editorial by none other than Professor Eugene Grunwald, which came in JAMA Cardiology. And really thinking about there is no such thing as too early for TAVR in asymptomatic severe AS. So I think it's really opened a Pandora's box. It kind of expands a lot of indications. So from where we started with extreme surgical risk to high surgical risk to intermediate surgical risk to low surgical risk, now we are moving further to not just low risk but also the asymptomatic aortic stenosis. And this has actually been based on a lot of data that we had in the year, and we can look at some of that data. So let's look at the partner 3. And the partner 3 was in a population of severe asymptomatic aortic stenosis who were at low surgical risk, TAVR using the SAPIEN 3, so it's evidently Edwards sponsored, was compared to surgery. And the simpler the TAVR, the better the results, right? So there was a reduction in primary endpoint of death, stroke, or rehospitalization by 46%, and components of primary endpoint favored TAVR, both at 30 days and 1 year. And there were multiple sensitivity analyses which confirmed the robustness of the primary endpoint. So the study design was about 1,000 patients, 1:1 randomization between a surgical biprosthetic valve compared to a TAVR. Follow-up was 30 days, 6 months, and annually through 10 years with a composite of all-cause mortality, stroke, cardiovascular rehospitalization. And we all know how the SAPIEN valve has actually been a gold standard balloon expandable valve, how it has evolved in technology, in terms of decreasing PVL, in terms of having better access or easier access, and in terms of expanding our size armamentarium, which is available to us. And when we looked at this primary endpoint, we definitely we know that whether we use a p-value of non-inferiority or of superiority, we did have benefits. So the key takeaway of partner 3 showed that in low risk patients, tower was superior to SAVR at reducing death, stroke, or rehospitalization at 1 year. So I would like to open this out to my colleagues. Dr. Sarita, what are your comments and how would you like to interpret the partner 3 results? Dr. Sarita?
So this has actually opened up a whole new vista that, low risk patients, we can also do it. But then they also included rehospitalization in 1 year. And they didn't really see a very huge difference in the death, in the stroke, but they did see a huge reduction in the rehospitalization at 1 year in these patients. So while, yes, it had very good results, and it was shown to be superior. But then I think the rates of rehospitalization actually skewed the results in this way.
Yeah. So, Dr. Praneeth, any comments from your side? Because it's, the earlier the tower that we do, I mean, I look at my own small cohort of where we have postponed for various reasons, logistics, financial, our confidence or the confidence of the patients. And we find that when we postpone them, we kind of end up with a lot of what we used to call rota regret for rotational atherectomy. We call it as tower regret because as the patients get older, they get sicker, they tend to have more complicated course. So it is intuitive that if you are performing the procedure earlier, and I know that the next bastion which is going to be addressed is why even wait for severe aortic stenosis? So we know that there is a certain natural history of disease, but we'll not get there. I will just open this for discussion to Dr. Praneeth.
Yes, sir. So we want things to be simple. Patients also want to get the things as easy with less pain as possible. The idea looks attractive that if you can get away with the problem with a simple procedure like a transcatheter valve replacement, it will always be better. But the question, this may not be true in Indian subset because for us cost is an important thing,
Very
where
important.
most of
Yeah.
the patients are not insured and many of them they do have to pay out of the pocket. And currently the cost is definitely 2 to 3 times the in comparison to surgery. So if you only look at the data point of view, it looks better, but we also need to consider the cost as an important aspect. So I would say for some for whom cost doesn't matter, probably then try to make it as simple as possible, and you can go ahead and get TAVI done because it seems to be in comparison to surgical valve replacement. However, for some where cost seems to be an issue, I think surgery should be offered to him because, in my opinion, cost is an important factor to
More
consider.
than just cost, I would put it just one more small thing that as we are dropping the severity and
Yeah.
the risk status, we are coming to younger and younger
Yeah.
patients. And there also a durability also is something which needs to get as well established. I know that we have reasonable data on durability, but we need to factor that when we talk to our patients. I mean, in every outpatient or every second outpatient, we have this discussion with somebody, and the patients do ask. I mean, there are some patients who come and say the tower is their personal preference because they don't want to go through a major sternotomy based surgery, and they would rather be back in saddle and working, in maybe a few days rather than a few weeks. So all this has to be considered, and you're very right. Costs and logistics will form a very important part. but the drop in expenditure, the drop in costs, as much as we had expected with the amount of numbers that have grown, have not probably happened. So there is some technology cost, but I think we should get them at much lower costs as time goes by. So with that, we can just review this because, how do you follow your patients with severe aortic stenosis? Suppose somebody is asymptomatic. How often do you resort to doing, say, a stress test? How often? Because when we were doing our DMs, a stress test in severe aortic stenosis was contraindicated, and you could be failed if you actually suggested that. But today we have a lot of people who are evaluating this or just looking at markers of rapid progress to symptoms, which can be BNP, which is more than 3 times normal, or LVF less than 60% on 3 consecutive measurements. And the tower unload told us that AS can progress rapidly. It is acceptably safe. And compared with clinical surveillance, preemptive tower is not effective in reducing death, stroke, or heart failure hospitalization, and more evidence is required. So if you really looked at it from the 2020 to 2024, we had newer trials like Avatar, the early Tower, and the Evolve trial, which again looked at age, anatomy, replacement strategy. And early Tower and Avatar extended the follow-up, but early Tower was the first trial to compare preemptive Tower to guideline-directed clinical surveillance. But it should not be forgotten that there was no blinding and there was no SAVR arm in early Tower. So if we look at Avatar and early Tower as 2 trials, we can just look at them and compare them, because early Tower were asymptomatic, and 1:1 randomization of about 900 patients, and minimum follow-up was 2 years. Avatar was again, it was SAVR or Tower with compared to clinical surveillance, and the early Tower actually showed us that it aligned with recent reports indicating that there may be an improvement in outcome, and was superior to clinical surveillance in reducing incidence of death, stroke, or unplanned hospitalization for cardiovascular causes. So this is what we got from early Tower, and these are patients who are being compared with just being on follow-up, and the number needed to treat at 2 years was only 6 for getting a benefit. So to conclude, in low-risk patients with symptomatic AS, early Tower and Avatar 5-year follow-up confirm better clinical outcomes with the strategy of preemptive AVR, whether in Avatar you had surgical and Tower, and early Tower extends this conclusion to older adults treated with transfemoral Tower, and preemptive AVR leads to a significant reduction in unplanned heart failure hospitalization. And in early Tower, 70% of patients managed with watchful waiting did convert to AVR within 2 years. So despite close clinical surveillance, 1/3 of these converted to AVR due to development of advanced symptoms. So as a takeaway, I would say that we come back to Dr. Brunwald's editorial, and we actually concluded this at the end of last year. The editorial just came last week, wherein we think that this is something which is going to become part of our, we should keep the AS progression top of the mind. So I just want to know from Sarita, do you actually do you perform stress tests in patients with severe asymptomatic severe aortic stenosis?
So currently, in our setup, we don't. That's the
All right.
honest thing.
All right.
But in this trial, they did do that. And which is why the results are so very surprising in this trial, because so many patients who had a negative stress test, they crossed over into the Tower AM so early. So the graph started diverging very rapidly right in the beginning. How is it possible that a patient who 6 months ago or 3 months ago had a negative stress test suddenly crossed over into the Tower arm? And it was seen that it was just on the basis of symptoms. There was no objective evidence for them crossing over into the other arm. So this trial actually came in for a lot of criticism. One was that this trial had a fatal flaw. The fatal flaw was that all of the patients knew that they had valve disease, one. The second was the endpoint choice in the early TAVR trial was a problem because one of the major endpoints which they looked at was unplanned hospitalization. And the difference in the unplanned hospitalization was 21% versus 42%. That's a huge difference. There wasn't very much difference in the death and in the stroke because it was 8.4 versus 9.2 in death. And stroke was only 4.2 versus 6.7. But the entire difference was because unplanned hospitalization was double. Again, how do you explain that in patients who had a negative stress test as early as 3-6 months ago? Again, the other arm was faulty because they kept a clinical surveillance arm. They did not keep a medical treatment or intensive medical therapy arm. Also, the trial population was entirely white with a low surgical risk. The STS-PROM score was only 1.8, and that's a problem. Also, is it generalizable? Do we apply it to all populations? Because it was only done in the white population. Also, a portion of this trial was done during the pandemic, and it is considered that it may have affected the results. So, and of all the patients who underwent this trial, we have to understand the concept of faith healing and subtraction anxiety. So all the people who underwent the early tower who were asymptomatic were faith healed. And the people who did not get it, but they knew they had a valve disease and they felt a subtraction anxiety. So they complained of symptoms and crossed over into the tower arm. So this trial has a lot of criticism, but the results are there for us to see, and it might affect guidelines in the future. We don't know about that, but there are flaws in this trial, I would say.
Yeah, I completely buy your points. And I think that's very nice that you brought this out in this fashion rather than just blindly accepting it. However, we have all seen in clinical practice that number one, your stress test can be quite dubious because in severe aortic stenosis, because of the afterload mismatch, we don't know when the patient is actually going to become symptomatic. And if you go with the old 1963 paper of Ross and Brunwald and the 532 formula, which we kind of still use as our gold standard when we are counseling patients, I don't think that the tipping point analysis can ever be perfect because we know that some patients actually we tell them, okay, people come back to us and say, my insurance is going to be due in May, can I come back and see you? And suddenly you realize in the month of February that the guy is admitted in the middle of the night with pulmonary edema. So we need to, it may have been arrhythmia driven, it may have been anything else, but we also know that some of these cases do progress very fast, very suddenly. But Dr. Praneeth, over to you for your comments.
I'd probably compare this to the coronary artery disease subset, where for a chronic coronary syndrome with an ischemia trial, we have to manage them medically and not revasc and what are the outcomes. So again, if we look into those subset, how can we leave so-called mid to proximal LAD saying that there is no event and relief of angina to compare. So similarly, in this subset, because these patients are so-called asymptomatic, truly believing on patient symptoms is sometimes challenging. And I believe in India, doing a stress test is definitely a challenge, be it the setup, be it the experience of the person doing the stress test. So all these things are a challenge to really bring out symptoms. And as ma'am mentioned, the progression of the disease itself is quite variable and unpredictable. And the so-called regret, as you were mentioning about, did we lose them when there was an opportunity to fix it? And then they do end up having a complication and an opportunity missed. So in that regard, I believe it's a individual decision that we need to take, and probably we should not go completely with the trial. And if in case we believe that the patient will get benefited with the early TAVR, I think it should be offered to patients.
So just to conclude, we don't have the ideal biomarker yet.
Yeah.
We don't have the ideal tipping point yet to actually be able to decide it. But we should, at the end of these trials and reviewing this literature, and despite the faults in the trial, we should definitely keep an open mind and talk to the patient about his or her preference for such an approach. That is, I think, what we would say. Now we must shift track because we can't only be discussing, we can keep discussing early TAVR, avatar, and partner 3 till the cows come home. But we all know that our coronary interventions, we do use imaging, and our 5 treatment goals would be optimal lesion coverage, optimal stent expansion, no unintended stent deformation, no luminal masses, and avoid or minimize the stent malapposition. And we, Lawrence Raber, probably a few years ago in Eurointervention, gave this brilliant diagram, which we put in every cath lab just to remind our fellows that we like to put a stent from normal to normal, or less than 50% plaque burden to less than 50% plaque burden. We avoid significant malapposition with an axial distance of less than 0.4 millimeters and 1 millimeter length. We must make sure that the MSA is adequate, which again, we can take either by Ultimate or IVUS XPL. We can use different formulae, but it can either be the average reference lumen of more than 80%, and we should not have any significant dissection, which is beyond, definitely not beyond intima, which is less than 60% and less than 2 millimeters in length. But the last year we had the Octivus, which is an OCT guided PCI, which demonstrated comparable results to IVUS guided PCI at 1 year, with the target vessel failure being 2.5% versus 3.1% in IVUS, with fewer major procedural complications in the OCT group, with reduced procedural time in the OCT group, and no difference in contrast-related risk between OCT and IVUS. And this is what wherein we hoped, and that is why in the guidelines, both IVUS and OCT could be considered in patients to optimize stent optimization. And the Octivus, to conclude, showed that OCT guided PCI is non-inferior to IVUS guided. There are a few caveats. We still have challenges with left main ostium. We still have challenges with any aortoosteal disease for that matter. We still have challenges in patients with CKD where we can use contrast substitutes, but we still have challenges. Any comments, Dr. Sarita?
So I think the beauty of this trial is that they actually show the problems that we've been worried about when we use OCT is that typically the contrast gives us great images. Although I also do saline OCT a lot, but typically I still get better images with contrast. And most operators are used to doing it with that. And contrast-induced nephropathy was considered a problem in OCT. Now, Octivus has shown us that contrast nephropathy is actually not a problem when you're using OCT. Because when they compared it with the IVUS arm, it was 1.4 versus 1.5. So there was actually no difference in the contrast nephropathy. And also when they looked at the complication rate, there wasn't a difference. So this actually taught us that OCT and IVUS are both imaging modalities which can both be used safely without any increase in the incidence of adverse events. But the important thing is that imaging improves our results. It doesn't matter if you're using OCT or if you're using IVUS. Yes, there are many things we are able to see more finely on the OCT than on the IVUS. It's also easier to interpret than the IVUS. And I think the important point is that use imaging more in your procedures. Both these are safe enough.
Yeah, that's why both the IVUS company and the OCT company made an algorithm which is like almost an AI-based algorithm, which is like MLD Max or IVUS 1 to 3, which is actually recommending to us to use it in all cases, though the practicality of that can be questioned. Dr. Praneeth, your comments before we move on to the next trial.
Yeah, I concur with comments made by Dr. Sarita that imaging definitely helps us know better, and definitely it will improve outcomes provided we are able to use it in each and every case. Practically, that is a challenge.
All right. So we again look at another trial called the Occupy, which is OCT guided versus angiography guided PCI for complex lesions. And this was about 1,604 patients. The hypothesis was that OCT guided PCI would be superior to angiography guided patients. And there was a 1:1 open label randomization to OCT guided and angiography guided group. And they, again, found that the stent optimization, the acceptable stent expansion was seen in about 73% cases, apposition in about 80%, and acceptable edge dissection in 99.6% cases. So patients meeting all optimal criteria were about 71%, and suboptimal were 29%. So they basically compared those with stent suboptimization and those with optimization, and really you did have a p-value of 0.001. So there were some limitations. It was unblinded, and it is pretty clear those had potential biases. The event rate were lower than expected, so there was reduced power. There was a shorter follow-up, and of course this has been performed in South Korea, which has extensive operator experience with intravascular imaging. It's almost every case in Korea and Japan would probably get an intracoronary imaging, which is unlike what happens in any other part of the world. So considering this, in this multicenter trial, OCT-guided PCI led to a reduced risk of one-year composite of MACE, and the main reduction was driven by lowering spontaneous MI and TVR without raising concerns, as was discussed in the previous trial, of contrast nephropathy. And in the OCT-guided PCI group, patients who met the pre-specified criteria had a significantly lower MACE compared with suboptimal results. And these findings do confirm the therapeutic value of OCT as an effective intravascular imaging modality. I think quite a no-brainer. It has added substantial amount of new data, but we still need to do something more. And these are the questions for us. Which lesion types benefit most? And I'm going to throw this open to Dr. Sarita and Dr. Praneeth. Which are the places where you would insist on using intravascular imaging, and preferentially OCT guided or IVUS guided imaging? Where do you use IVUS more? Where do you use OCT more? And whether there are modest differences in outcomes between OCT and IVUS? And that was also discussed in the last trial. But Dr. Sarita, your comments on this?
So typically places where when I'm doing a procedure, which is left main bifurcation, I always like to have imaging on hand. When I'm doing a bifurcation PCI, when I'm doing an patient with ultra low contrast, or if I'm doing longer lesions, I typically like to have imaging on hand. And so when we're saying IVUS, I like to use it more in patients which I'm doing an ultra low contrast or a no contrast procedure, because they possibly have CKD or they have very severe LV dysfunction, and I don't want to give them a dye load at that point. But having said that, a lot of centers have only one imaging modality. And if you just have OCT on your table, you can still do the procedure with an ultra low contrast using saline contrast. You can using saline, and at the same time, even for left main, you can do a distal left main bifurcation using the OCT. It gives you great results. You can actually see the side branch very well. You can see the crossovers very well. And even if you're doing an ostial, you can just take a telescope, and the proximal portion of the telescope is infrared compatible, and you can do your procedure with using OCT also. So left main bifurcations, long lesions, bifurcations in other areas, patients for whom I need to do an ultra low contrast procedure, I would like to use imaging all the time.
All right, Dr. Praneeth, your comments?
Yeah, as I said, the more complex it is, the more is the incidence of MACE, and that is where the value addition of these imaging come into picture. And as ma'am said, the more complex the lesion is, it should come as an by default that imaging should be there. I would say the difference between ICT or OS will depend on the operator. These days we have high definition IVUS, which makes the image clarity a bit more readable and more user friendly in comparison to OCT, which is more visible. You can interpret images better. So the operator has to choose based on what is comfortable and what is available to the person. And for CTOs, probably IBUS has an edge, particularly when you are trying to do subintimal entry and retrograde entries. Probably that will help in re-entering the main lumen with the help of IBUS. That is where probably IBUS scores over OCT. But definitely it will add value. The only challenge I feel is because of the short monorail, sometimes though we would like to use IBUS or OCT, sometimes we fail to deliver the catheter, particularly in angulated and calcified lesions. That is where probably, though it needs to add value or it will add value, it unfortunately it doesn't give the information when we need the most, which is, I believe, a part of the hardware issue, which hopefully will get better and we should be able to use it in almost all the cases.
And I agree with Dr. Praneeth. I failed to mention calcific lesions. I think it's a great tool to image before we go in one in calcific lesions and one in in-stent restenosis. Both of these areas, it really helps us. For example, in ISR, I typically get to decide whether it's neointimal hyperplasia, it's neoatherosclerosis, or there's a biological cause and there's a stunt under expansion, or is there some calcium behind, or is there a stent fracture? So I think in ISR, it really helps me to decide what is the way I'm going to address this disease. Second is with the advent of the DCBs. I think imaging has a great potential over there because when we are planning to use a DCB, it's important to image and see what is the amount of dissection do I have over there and can I safely get away with using a DCB. And when I'm imaging in calcified lesions, I typically get to see what is the degree? Is it 360-degree calcium? What is the depth of the calcium? Is it superficial? Is it deep? Do I have a calcium nodule over there? So I get to upfront plan my case, whether I'm taking rota, I'm taking orbital, or whether I'm going to shock wave this patient, or maybe I'll need a combination of technologies, or maybe I could just get away with a cutting balloon if it's a smaller arc of calcium and it's superficial calcium. So basically, I think in calcified lesions and in in-stent restenosis and in areas where I'm planning to go in with a drug-coated balloon, those are also areas in which imaging has a great role today.
Great points. But if I were to ask a counterintuitive question, suppose you had a new center which was a little cash strapped and you had to choose one imaging modality which you had to buy. What would you recommend? Would you recommend buying an IVUS or would you recommend buying an OCT?
So I'll say that I have all the modalities in my
You
center.
do. You're working in a lap of luxury. But suppose you to start a new center, you have to have one imaging modality.
So let me just complete. The first modality which I brought was actually an OCT. I didn't end up buying the IVUS first. I ended up buying the OCT first. But yes, today I have all the modalities. And I think it really helps if you can have all the modalities.
Great. Praneeth, suppose you're doing a little more CTO work, I guess one would think of, for example, if I were to advise somebody, I would probably say, yes, best to have both, but if I were to have one, start with an IVUS. Dr. Praneeth, your comments?
As I said, between both of them, I think the learning curve is probably easy with OCT because the image resolution is better. So probably for somebody who is beginner, I think OCT helps you learn faster versus the ultrasonic or the gray images of IVUS. Unless the definition is better, particularly with high definition, probably interpreting will be a challenge unless you are trained your eyes. So between those two, I would say OCT will be preferred.
So, Dr. Dal, just for, just because we're all friends here and we're discussing, there's one thing. In IVUS, it's very easy to do. And the catheter tracks very easily. And you don't have to give, forceful injections of contrast and all those things and all. But the interpretation of IVUS is more difficult. And with OCT, the interpretation is very easy. But it's more typically tougher to pass that catheter through. Typically, you have to give injections many a times. You don't get it at one go. But the interpretation is very easy. So I think each modality has its beauty. It's best if we have both.
Of course, best if we have both. All right. So we move on to a multi-stars AMI trial, which again, coming back to this question, which has rocked us for many years about complete revasc with multivessel PCI for for STEMI. And again, multi-stars looked at whether immediate multivessel PCI is non-inferior to staged multivessel PCI based on 1 year risk for composite of all-cause death, non-fatal MI, stroke, unplanned ischemia-driven revascularization or hospitalization for heart failure. And I'll just cut short that it is about it is a 1:1 randomization, and the primary outcome was death, non-fatal MI, stroke, unplanned ischemia-driven revascularization. And what it said was that immediate PCI is superior to staged PCI. The median was 37 days following index PCI among hemodynamically stable patients presenting with STEMI and with evidence of at least one other non-culprit vessel that was amenable to PCI. So, Dr. Sarita, does this change your practice or your as it is doing immediate PCI? What is the approach that you take? Do you delay it? Do you do it as staged in the same admission, or you stage the admission itself?
So I think there are a lot of factors when a patient comes in with an acute MI and we do the angiogram and we find this multi-vessel disease. So typically, the things that we typically look at is one, that when a patient comes in with an acute MI, his hemodynamics are usually haywire. So if his hemodynamics are haywire, that helps me to decide whether I'm going to just do that culprit vessel at that time or do the second vessel at the same time, or maybe stage it. One thing is very definite. I would do it in the index admission itself. I wouldn't send the patient back home. I typically may stage it, but do it in the same index admission. One is the hemodynamics help me to decide. The second thing which helps me to decide is also if it's an elderly patient, diabetic, and I don't have his lab reports at that time, because you wouldn't have the creatinine or the hemoglobin of that patient at that time when he comes in with an acute MI. So elderly patient, diabetic, I would typically open the culprit vessel and stage the procedure maybe the next day or a day after. The third thing which also helps me to decide is which vessel. So for example, if you're opening the LAD and you find a high-grade stenosis in the circumflex, you might as well go ahead at the same time because you're already hooked into that system. But that's not the same thing if you have an RCA lesion there too. And the fourth thing is, what is the time of the procedure? If I'm coming in at 2 o'clock at night and the patient is crashing, I would typically do the culprit vessel and say, okay, send him to the ICU. I'm going to come back and do the next vessel the next day. Because I don't have the labs, the hemodynamics are there. The patient stabilized because I opened his culprit vessel. So there are a lot of factors which go in deciding whether you're going to do multi-vessel at that time on the table. But most of us in our practice, in that index admission, would do the multi-vessel and then send the patient back home. We wouldn't call him back after a month to do the next vessels.
Sure, great points. I think you referred to them very, very lucidly, and this is how most of us do our thought processes, align our thought processes. Dr. Praneeth, any differences or
I think it
you
also matches to the expertise of the operator and, as ma'am rightly said,
the
the
team
given circumstances. If
and the
you're,
team?
yeah,
because
and the
because
team, yes,
hemodynamic support,
yes,
all that is also so we necessarily would like to make sure you do something efficiently and optimally.
yeah,
All
correct.
right. So again, there was this there was this fire trial, which again showed that when you are doing so, how often are you resorting to using physiology-guided complete revascularization compared with only culprit-only revascularization? And here they compared the difference between QFR versus wire-based physiology. In the according to the clinical presentation, they looked at patients with NSTEMI and STEMI, and the fire trial suggests that the overall trial remains largely consistent in patients with NSTEMI and STEMI at presentation. So this was something again that it was by and large the takeaway was that the physiology guided complete revasc reduced the major adverse cardiac events compared with only culprit only revascularization. Again, something which there are some challenges with assessing wire based physiology in patients who are acutely sick or with STEMI. And when do you I mean, in your practice, how often do you tend to use a wire-based physiology determination in patients with STEMI, especially for the non-culprit vessels? Dr. Sarita?
So I think the FIRE trial was important because it was done in a subset of patients who were elderly. The median age of all the patients in this trial was 80 years. So one thing that this trial also brought home to us was that it was safe to do a complete revasc in these elderly patients. That elderly patients should not be denied the therapy because it's unsafe. So it was safe. The median age was 80 years and it was safe, and the trial had good results. So one thing was that. Now, regarding physiology-based versus angiography-based only, why one of the reasons they put in physiology in this, that was there shouldn't be any unnecessary additional revascularization. So when they used physiology in this, so actually a lesser number of non-culprit vessels ended up being stented. And that made the procedure actually safer for these patients because they were elderly patients. So they were elderly patients who did well, who had a non-culprit vessel PCI if an FFR was done and it was positive. And a lot of the time the FFR came negative and the non-culprit vessel didn't have to be touched at all. So the number of non-culprit stentings also came down, and it was important because this is an elderly population and will be requiring DAPT for a long time if you're putting in multiple stents. So all of these things were very important. But the good thing was that uh, using physiology guided and in elderly population, they ended up with great results. So yes, in an acute MI situation, again, using FFR on the non-culprit vessel is not really very helpful because the results may not typically be very clear. You may have false results. But then I think a lot of these patients, if you could stage the procedure, do the culprit the first day and then wait for a day or two and do the non-culprit FFR, that would help.
So conceptually, this is where the non-wire-based physiology, the QFR estimations actually come in, because that may take away some of the pain points which a wire-based estimation would happen with in STEMI, because that is not really, that's going to be mathematically driven and not going to be dependent so much on tissue edema and slow flows and what have you, which are actually the factual causes by which physiology in an acute situation does not has always been suspect. I wouldn't say has been questioned, but has been a kind of suspect. Dr. Pranit, your comments.
Yeah, your points is valid, sir, because a wire-based physiology assessment versus a non-wire-based, we understand the challenges of an FFR wire, particularly because it's a bit stiff. Passing it and trying to make a measurement and maybe causing a wire dissection, all those things is probably defeat the whole purpose of doing a physiology-based assessment. And if these issues can be removed by using a non-wire-based physiology assessment, then you are getting the advantages of the physiology assessment without adding to the complexity of the procedure. So I think if we can balance both of these things, and if it is available, then probably knowing the anatomy or the area under risk being more clear and offering the PCI to that non-culprit vessel will definitely improve outcomes.
Great. So
65% of the patients actually had a wire-based assessment in this.
yeah. So it also gave us a chance to compare wire-based versus non-wire-based, because as a purist, you would still kind of doubt the non-wire-based physiology estimations, because they probably, anyway, that's a topic for another discussion. But we move gears because we are running short of time, and we move to pulmonary embolism. And we know that we have a lot of tools to use in pulmonary embolism. Till now, we were just doing rotating pigtails and infusing thrombolysis. We have some standard catheters and some specialized catheters. You have the ECOS, the Thrombolex, which has a nitinol expandable basket, and you have infusion catheters. And there are some mechanical thrombectomy options like the Penumbra CAT 1216, float reavers, and AlphaVac, which is available. But these are beset with issues like the float reaver would have up to 24 French and would lead to a lot more blood loss, whereas a Penumbra would have potentially more controlled blood loss. So the peerless randomized controlled trial was comparing the catheter-directed thrombolysis to large bore mechanical thrombectomy, and large bore mechanical thrombectomy was associated with less clinical deterioration or escalation of therapy, faster clinical and hemodynamic improvement, less ICU stay, and fewer readmission. So they compared as a generic modality a large bore mechanical thrombectomy versus catheter-directed thrombolysis, and they showed by the win ratio analysis that large bore mechanical thrombectomy was superior. So I'm going to just come to the key takeaway that it had lower rate of clinical deterioration and bailout ICU utilization compared with catheter-directed thrombolysis, with no difference in mortality or bleeding. Actually, even we have tended to use large bore mechanical thrombectomy. We do find a fair amount of blood loss, but I would here open this trial for comments by Dr. Sarita.
Yes, actually, we've used these devices, and yes, the resolution and the clinical improvement of the patient have been faster in that situation. But they are large bore access devices, and you have to be very careful when you use them. So typically, yes, but we've had good results with this.
Yep. Dr. Praneeth?
My experience in this regard is limited, so I think my comments will be more generalized. Uh, Technically, both the options seem to be attractive, but I believe mechanical thrombectomy, because of the large bore access, probably it will cause increased bleeding is what we believe, but the trial shows that there is lesser bleeding, probably with increase in expertise, and also currently because of the TAVR experience, probably we are well mature enough to handle large bore access. Probably that is helping us access or manage these large bore vascular accesses better, and overall improving the outcomes. I think at the end of the day, the diagnosis of pulmonary embolism is important. I'm glad these trials are happening where the awareness is increasing. We are able to diagnose them more, and we are able to equally offer them better options rather than only sticking to thrombolysis. I think these trials should happen, and we should have many more devices to help pulmonary embolism patients get better faster and earlier.
Great, great. Because this is we know that there are many other trials which are like knocking on the door, and which are going to happen, and we can also extend some of this large bore access to a unique kind of situation. And then there's been a rise actually in right-sided infective endocarditis, especially in IV drug addicts and people who are with cardiovascular implantable electronic devices and chronic indwelling catheters. And these tricuspid valve vegetations have issues. So similar experience with can be used, by which these devices can actually be used to pull out these so-called vegetations. And there's been some early experience, although there have been some concerns. So I think we have come to 9:30. And Anand, do we do one more trial, or do we call it a day and come back to fight another day?
I think so. We can always have all means to come back once again and have an
Yeah,
elaborated discussion
I
rather
think
than cutting it short.
because we've covered from early tower to we've covered a fair spectrum of STEMI revascularization, multivessel disease. We've covered a little bit of pulmonary embolism, and we have some exciting stuff which is yet to happen. But I think we are done with 1 hour, and a lot of people who may be listening on and I could see Sarita was still in scrubs, so she has to get home as well. So unless she has 4 cases still lined up, I think we'll call it a day, and I'd like to hear from Dr. Sarita and Dr. Praneeth their comments before we close.
I think it's been an interesting evening, and right from discussing early TAVR to asymptomatic TAVR, and we're going on to discussing multi-vessel revascularization in the index event and physiology-guided revascularization, and then using large bore devices as compared to only thrombolysis, which we had earlier, and now the penumbra, the FlowTriever. It's been a very interesting evening discussing about all the latest advances, as well as discussing about the time-old problems of whether we revasc in the same sitting or not. And I think the discussions could just go on and on, but in the interest of time, I think we will have to close the session.
All right, Dr. Praneeth, your last comment, and then we'll hand it back to Baishali.
Yeah, I think as ma'am said, we can discuss when like-minded people come together and when there is a lot to discuss, particularly these interesting topics. I think we can go on. It just the time is the limit where we have to respect time of both ours and others. I think it's better to stop and we can come back again.
Thank you, and thank you for this opportunity. I hand you back to Baishali and Anand for concluding.
Yeah, thank you so much, sir. Thank you so much for expert panel. And as rightly said by all of you, that the discussion can go on, and that was the whole purpose to have this program in the first place. Thank you, expert panel, Dr. Sarita Rao, madam, for sparing time with us, and Dr. Praneeth sir, for your evening with us, and all delegates for joining in for program. And thank you, my field colleagues, for making those invitations. So thank you very much once again, and I wish you pleasant evening and good night. Thank you.
Thank you.
Bye, Sarita. Bye, Praneeth. Take care. God bless.